especially when I was actually asked a panelist with other speakers, because we did really extensive study PhD work with Prof. Razi on this. He's a prof. So just look at the pterygium. I just want you to look at the pterygium. Remember that when Dr. Aini says you actually have a zonal part of the zonal part. You actually have center, you have paracentral, you have peripheral. Right? Don't talk about meridional first. We just don't talk about sectorial first. You take a zonal. You look at that pterygium, you can see that the pterygium actually encroaching at the margin. Can you see that? Do I have another pointer? Another pointer. Kalau ada, I forgot. That's okay, sir. You keep yours. I know I have everything in the back. So now that's one thing. I want you to see it. As it goes inside, you know that it's approaching to the center where you take the K for the IUL calculation. Compared to if you have peripheral, limbal or paracentral, this is actually encroaching to central. That's one thing. The other thing that we don't go for. Thank you so much. Right. So the other thing I want to highlight is this. When you look at that, we actually look at the parameters in different way from others to know that how much does this actually cause distortion to the cornea. You look at the clock hour, right? That clock hour is not that much. It's from 8 o'clock to 10 o'clock, about 2 clock hour, right? But that clock hour, and then we look at this area in relation to the total cornea. What is the total cornea involved in this particular pterygium? So you said this could be 1/8 of the total cornea, right? So you have the parameters on a zone, on the clock hour, and what are the total affected. So when we study all this, as all other study look at, you can't predict based just on these three things, how far it goes in, the clock hour, and the total affected. The most predictable in our study looking at how come this actually been really impactful to the eye is the thickness of this particular pterygium. So if we actually draw like this, so you can actually look at the thickness, especially across the limbus. That thickness can cause a lot of problem. And if you look at that, that is highly fibrovascular, and you can see that there's a lot of collagen tissue over here. That induces a lot of actually problem with the curvature over here. Just looking at that, yeah? So that's number one. So not all pterygium they said on 2 mm should be okay, 1 mm in should be okay. No. We have done this even in the lab, looking at taking this out, look at the dry weight, the wet weight of this. The weight, the fibrovascular component is this more important. So if you have cases like this, you're a bit worried because you know it induced a lot of anterior curvature issue. Got it, yeah? That is the first one. Can you go to the pre-op? Pre-op, okay, this one. Now we come to this, yeah? Let me just actually look at it, just to highlight certain things. So if you look at this, refraction-wise, patient on the left eye have 620 with this particular minus 1.75 and minus 2.75. Let's don't talk about the the axis first. But this is refraction that you get, meaning that it can still be refracted. But when you look at the corneal aspect is minus 40. If you are the technician who doing this, you know that actually something is actually compensating this aspect. Something is compensating this aspect because if actually the lens doesn't have compensatory mechanism, it should be something like this. It should be high aspect. At least you know that. Okay, this aspect, because we haven't removed that. This one we haven't removed that. Okay, so now at least at that particular time, you have in mind that whatever astig that we have from cornea is now been masked from your lens. Understand, yeah? Now then Dr. Akmal remove the pterygium. Remove the pterygium. After that, remove. So once you remove the pterygium, then you see this. Is that correct? This is actually 6 months post-op, eh? So you have minus 3.5. And then immediately you actually have seen the stabilizations of this into minus 7.88. So if you do the calculation, you would know that if you remove the cataract, which compensate, which actually give the counter of minus 7.88, meaning that the cataract must actually give at least plus 4 to give this. If you remove that, you know that you're going to get only this for your corneal astig. Yes?
Can you just repeat?
Repeat again? Repeat again, eh? So, this is after Dr. Akmal basically removed the pterygium nicely. Now, you look at the astig, corneal astig have reduced into half, from minus 14 to minus 7.88. Now, then that particular pterygium as a flash have actually, been removed above minus 7 of the astig. That one you understand, eh? Now before I go further, let me just show you what happened to that cornea. We don't have a photo scan. So what happened is actually when you remove, the cornea doesn't maintain the same anymore. It have that still. And meaning that if you look at thickness and fibrosis, there could be some fibrosis over here, some thinning over there, that make sure that you still have minus 7. It's not a normal cornea, still have a minus 7, right? But the refraction is minus 3.5, which in cataract, you're going to remove it, then the minus 7 will manifest. Understand, eh? Okay, let's go to the next. Okay, let's go after all. We go to that later on. Okay. So it's not surprising that you get that minus 7 because it's monofocal. You get that, and then you have a shift of this. Now that you understand now, that is expected. If let's say we don't do anything, then it's expected that patient will have this. No. So now there are a lot of questions people ask. Then how come it become hyperopia? It become hyperopia because of the coupling effect. If you change the corneal curvature to the steep and the flattest will give you an effect, overall effect. It will. So that's why it becomes flat. Even you have the steepness because you do not know that steepness at what zone. You basically do not know at what zone that you have that steepness, but the flattening is actually the overall picture for the sphere. And that's why you actually have hyperopic changes post actually pterygium. You don't have these hyperopic changes if you have paracentral. Mana ada? Lepas pterygium buat paracentral, tiba-tiba hyperopia. And that's your fault. That's not the pterygium fault. If you look back all your cases, the one that hyperopic changes usually paracentral near to actually central. Kissing pterygium, all that. And then so this is just to explain to you what's going on. Yeah, what's going on. Now, we understand what's going on with this now. So there's a few things that we can actually discuss. First and foremost, what could we do for this patient? Let's say patient have no issue with financial and everything. The thing that we could do after the post-op, we immediately post-op of the pterygium, we immediately do the topography. If let's say there's no financial issue. So topography, then you can see whether this is actually regular or irregular. If let's say it's regular, then, and it's stable, then we can put toric IOL. Now, when you can you go back, Dr. Ikman? The aim of -1 just now. The aim, this aim, okay, this one, just now. The aim, okay, this one. This aim actually, in terms of management of refractive, we always have to correct the astig first. Because if we don't correct the astig, whatever that we aim, it becomes so haywire because the astig will take over. You know, astig will take over. So if you look at spherical equivalent, can you go back to the spherical equivalent that you showed us? Yeah. And if you look at that, if somebody always say, oh, spherical equivalent is actually 0, do you think the patient happy? And that's why exactly, that somebody actually asked me just now, does this mean if you get 0 plano, does it mean that this is actually without residual refractive problem? No. The way that we do in refractive is we take each component and actually look why it become like that. You understand? So meaning that, because I've shared podium with so many people saying that, oh, at least your spherical equivalent is 0. It doesn't do justice to the patient. You know, you ask this patient, you will not get 6.6. Not only that, you will not get that good quality. So this is really nicely actually demonstrated. So if we are starting to looking at the refractive surgery, the lens refractive surgery, we will going to decide how is the seal and how actually the sphere by itself before we go to the spherical equivalent mean. So that's very important. Yeah. So that's basically the take on but they are, so what to do with this patient now? Is that the question, or is it patient happy?
If you are encountered again this kind of case,
yeah,
how to avoid the hyperopic shift and how to?
So okay, let's say the same type of patient coming in, so you get the same kind of reading. For example, you get high. The first thing we say that you can actually predict what the pterygium will do post-op. So you can only assess after that. This kind of cases, you cannot combine, do it at the same time. You know? And some people say, just even though you might, that's the thing. I rather the patient actually you still do not see, but we actually regulate you, the anterior first, because you'll come and see me again if you're not clear, but I can settle with your cataract later on. So in other words, and the benchmark, usually people don't do the at one sitting. You do cataract and you do pterygium at the same time in cases like this. So we let the cornea settle, get the reading again, just like we will have. Let's say it's -7. From that -7, the best that we can, if let's say the patient have at least topography. Now, if you don't have topography, at least you must have a persistent K with the manual K. This optometry can actually help. If the optometry say that the manual K is actually consistent, it's not a difficult thing to get, then in that particular part, and there's no thinning. Remember, you must see as well whether there's actually a thinning. Because if you have a thin like that, you have to know that whatever incision that you do will change your biomechanical. If there's no thinning, it is actually wise to offer the toric IOL. Now the question is, the patient cannot afford. Ni ada kan selalu kan, patient cannot afford. Oh, that's tough. Because you know that whatever that you do, you will have that -7. Now if we do the limbal relaxing incision, it will not actually clear up. Yeah, clear up this particular thing. Yeah, it is deep at the 85. That is actually with the root. It's against. Yeah. So yeah. So if you have it again, I think any one of us will just look at what's going on, make sure whether it's regular, it's not regular. But then at the end, depending on the logistic of the patient and financial, if they can just put it, toric IOL is regular.
So that what Prof addressing the astigmatism, right? So how about this one, the spherical? How to?
Oh, the correction. You mean this is after implanted the lens, kan?
Yeah, after implanted.
After implanted the lens.
So So how to avoid the spherical hyperopic shift? Just now the provision.
Okay, that's the thing what's going on. The reason is actually, that's nothing that I said to you just now. You are correct. So not only because of actually, there must be incision that we do actually induces this hyperopic as well. So there must be. Is this actually temporal or is actually
Some superior.
superior guy? So you can actually get the feeling that, you know, there is actually, let's say, 2.75 kan?
So unpredictable, like the cornea.
Yes, that's correct. Yeah. But this contribution is all from the steep. Yeah, from the steep cornea. It might be, yeah. Yeah. If you do a temporal incision, it may be. Yeah. Yeah.
So how myop we need to
Aim for. In cases like this.
in case of high myop, average minus one,
Oh, we mean that if you have a long axil length, how minus that? Oh, okay. My answer might be different from other surgeons. My answer might be different. So you listen to all other surgeons say that I will aim a bit of myop, low myop. You know, they always say that. I never do that. I always go to plano. Why? Because the biometry that I use, the formula that I use, Barrett's, always get me where I want. But if you listen to others, they say it's safer for you to go a bit of myop, and which almost everybody's saying that. Everybody's saying that. So, but I don't do that. I always go to plano. You know.
depends on the formula that you use also.
Definitely. Yeah. But if there's, you can see that a lot of other surgeons who are doing this, they always aim it the longer axil length, always with a bit of myop. They use, rather than minus 0.25, they go to minus 0.4. They say the myop would like myop. That's what they say. Yeah. Okay, thank you. Sorry, I'm taking it on. Any other questions? Yeah.
I have another case of that. I think
No need, eh? Oh, yeah. Okay. Okay, so rubbish bag kan, eh?
short, just a quick.
Yeah, you can ask a question.
So this patient, there's any other treatment you can help them?
Of course, there's a lot. First and foremost, again, we have to look at the stability of that, whether it's stable or not. If it's a regular, you can actually put a circumflex. There's actually a circumflex lens that you can put a piggyback lens, circumflex lens. If it's not that bad, the cornea, if the patient has money, the corneal refractor can actually handle that as well. Now, there's a few. If let's say you're good at your intact, you can do something as well. If let's say there's no thinning of the cornea, there's a few. The only thing is where Dr. Iqmal practice that become very scarce, especially on finance. But we do have a few options to do this. Yes.
For Salcoflex, can you treat Aztec also so high? For
The
Salcoflex?
Sacroflex, they have a range. I'm not sure about -7, but they have a range.
So, but for small residual class 2 with the 100 Aztec and all that,
Yeah.
the piggyback.
Yeah, they can. It's a big lens, that's why you have to look at it. You just put in the sulcus by Rayner, I think. But they have their own scientists, when they actually communicate with you, they will actually calculate it for you as well. Yeah. And again, depending on that cornea, how scar up, if you think this patient can do well, there are patients who have kissing pterygium, it's quite scar up, and I say that rather than you actually put any IOL that can mess up the whole thing, I'll put IC8, their pupil. Yeah, the people, because at least they get good vision, and then because they don't want to do transplant post pterygium. Yes, please do.
Just a quick one. Just